I want to thank everyone for joining us for this webinar entitled Designing and Implementing Ideal Behavioral Health Crisis Systems. This is the second webinar in a three-part series on the topic of behavioral health crisis response services. We're absolutely thrilled that so many of you could join us for this webinar today to learn more about this critically important topic. My name is Sarah Kopelovich. I'm an assistant professor in the Department of Psychiatry and Behavioral Sciences at the University of Washington and core faculty on the Northwest Mental Health Technology Transfer Center. On behalf of the entire Northwest MHTTC, I'd like to welcome everyone to today's webinar with Dr. Ken Minkoff, a clinical assistant professor of psychiatry at Harvard University and senior consultant with Zia Partners. Before we begin, I'd like to address just two quick housekeeping items. If you have any technical issues, please submit your questions in the chat box and one of our staff can work with you. If you have any questions during the presentation, please submit these in the Q&A box and we'll compile them and review them at the end of the presentation. The MHTTC network is a nationwide network supported by the Substance Abuse and Mental Health Services Administration with the purpose of disseminating and implementing evidence-based practices for mental health disorders into the behavioral health workforce. The Northwest MHTTC is based at the University of Washington in the Department of Psychiatry and Behavioral Sciences. Our work spans Alaska, Idaho, Oregon, and Washington, and we aim to provide high-quality training and technical assistance in evidence-based practices to the behavioral health and allied providers who work with individuals who have or are at risk of developing a serious mental health condition. It's our intention to always be mindful of using language that promotes recovery and culturally appropriate terminology. We encourage all clinicians to use and champion person-first language, which emphasizes the individual. Person-first language is a way to demonstrate respect and for a person's dignity and worth. Now, before we get started, I'd just like to take a moment to ask who we have with us here today. So I'm going to run a poll for everybody. It should come up on your screen. And the question is, which of the following option best describes your role? Physician, a healthcare administrator, clinician, social worker, or if you're in a different category, feel free to indicate other and then enter your role in the chat box. So we have a fantastic mix of attendees today. We have quite a few students, clinicians. We also have about 6% administrators, some funders, legislators and legislative staff, advocates, family assistance specialists. This is fantastic. RNs. Well, so without further ado, I'm excited to introduce today's speaker. I'm pleased to share a brief biography of Dr. Minkoff, and I'll note that this is a small sample of his many professional accomplishments. Dr. Ken Minkoff is a board-certified addiction psychiatrist and a preeminent expert on integrated services and systems for individuals with co-occurring serious mental illnesses and substance use disorders. Dr. Minkoff is a clinical assistant professor of psychiatry at Harvard Medical School, as well as the senior system consultant with Zia Partners, a private consultancy firm dedicated to helping systems and services improve care for individuals and families with complex needs. Along with his consulting partner, Dr. Christy Klein, Dr. Minkoff has developed a systems change toolkit that can be found at zialogic.org for the implementation of the Comprehensive Continuous Integrated System of Care, or the CCISC, which is considered a national best practice model for systems design for individuals with co-occurring disorders. Dr. Minkoff and Dr. Klein have provided consultation for CCISC implementation in over 15 states and 3 Canadian provinces. We are honored to have Dr. Minkoff share more about his work today and to learn more about designing and implementing behavioral health crisis systems in America. Thank you, Dr. Minkoff. I'll turn things over to you.
Well, thank you very much, Dr. Kopelovich, and I appreciate the kind introduction. I just wanted to make one correction. It's the toolkit is available at ziapartners.com, which you see on this screen, www.ziapartners.com, not zialogic.org anymore. We changed websites. So the title of this talk is Defining and Implementing a National Standard for Behavioral Health Crisis Response. And the framework that we're talking about is thinking about how to design and aspirationally create ideal behavioral health crisis systems for communities across the United States. And one of the things that, before I go, you'll notice that the slides that we're using were designed to do this presentation at the National Council's NatCon 2020 conference in Austin, which has been canceled. So you guys get to have the benefit of this presentation without having to go to Austin. Having an aspirational vision for behavioral health crisis services and behavioral health crisis systems is deliberately provocative. And I wanted to start by saying that for too long, we have thought in this country that it's okay if we have barely adequate behavioral health crisis services, like we should give ourselves a round of applause if we have anything that responds better than law enforcement and emergency rooms. And part of what this presentation is arguing, and the work that we're doing in the group for the advancement of psychiatry, which I'll be describing later, is to turn that around and to create a vision, knowing that we can't immediately achieve it, but nonetheless that if we have that vision, that we can start to make purposeful progress toward achieving the vision and demonstrating that we actually can do this as a nation and as a society. So the first part of the vision is that every individual and family in every community in the United States will have access to a continuum of best practice behavioral health crisis services that are welcoming, person-centered, recovery and resiliency oriented, and continuous through the crisis. Part of that vision and why we're being aspirational is to say that an excellent behavioral health crisis system is not a luxury, but it's an essential community service. Like other community services that we're all used to having, like police, fire, emergency medical services, and so on. And as such, every community should expect, like it does for those other essential community services, a highly effective behavioral health crisis response system to meet the needs of its entire population, just as is expected for the other essential community services. Further, a behavioral health crisis system in any community is more than a single crisis program. It's an organized set of structures, processes, and services that are in place to meet all types of urgent and emergent behavioral health crisis needs in a defined population or community effectively and efficiently. And while no system will ever likely reach the ideal, the aspirational goal that drives a person-centered continuous quality improvement process for behavioral health crisis systems is that, just as for emergency medical services in each community, every person receives the right service in the right place every time. Now you'll realize that currently, much everywhere, although there are systems, and you heard Dr. Balfour talking about her continuum, some of you did in the first of this webinar series. But one of the things that we learned as we were going through the research for putting this model together is that emergency medical services do hold this ideal in every community, and they do have an organized systemic response to make sure that people do get an appropriate emergency medical response in the right place every time. And thinking that we should have that for people with behavioral health crises, and by behavioral health, I mean mental health and or substance use, including overlap of those issues with people who may have cognitive disabilities or physical health challenges or other types of human service involvement, is a basic concept within a framework of health equity for people with behavioral health conditions of all kinds. Now, there are several different starting places that began the conversation that we began working on this idea of delineating the criteria for behavioral health crisis systems. One of those was through the work of the Interdepartmental Serious Mental Illness Coordinating Committee, or ISMIC, of which I'm one of the 14 non-federal members. And we developed a report. This is a congressionally created committee by the 21st Century Cures Act for bringing the federal departments together to work in a coordinated way nationally around people with serious mental illness, adults with serious mental illness, and children and youth with serious emotional disturbance. And one of the recommendations was to define and implement a national standard for crisis care. At the same time, there have been a number of different publications that have come out just over the past few years that have been advancing language about this intention. One of them is a SAMHSA publication called Crisis Services, Cost Effectiveness and Funding Strategies. And subsequent to this, just about a month ago, SAMHSA released a newer publication called National Guidelines for Behavioral Health Crisis Care. Came out in February, and it's another step in the direction of what we're talking about. The material I'm going to be presenting goes further than what's in that document, but there's another couple of publications which I'm going to mention a little bit later. And the question of what should be the national standard for crisis care and how should it compare to our expectations for other essential services has begun to be discussed. So recent materials that contribute to this are a technical assistance collaborative report for NASHBID, that should be NAS, National Association of State Mental Health Program Directors, called Beyond Beds, describing a continuum of crisis services beyond emergency rooms and inpatient care. A lot of work coming out of the Action Alliance for Suicide Prevention, notably Crisis Now, Transformation is Within Our Reach. And you guys can Google this for the wealth of materials that's being developed. The Meadows Mental Health Policy Institute in Texas developed a report 2 years ago or 3 years ago called Behavioral Health Crisis Services, a component of the continuum of care, elaborating sort of the elements of a continuum of behavioral health crisis services. And what led to our current work is that I'm part of an organization called the Group for the Advancement of Psychiatry, or GAP, and I'm the co-chair of the Committee on Psychiatry in the Community, which includes about 15 mostly psychiatrists, but we also have a representative person with lived experience, and we have a judge named Steve Leifman, who is well known as a mental health leader and is also the chairman of the board of the Miami-Dade County managing entity in Florida. And about 4 years ago, he asked our committee to help him with something he was trying to figure out, which is in his system, he wanted to know what were the standards for ideal system development that he could apply in his service delivery system. And out of those conversations, we began working as a committee on a project that has come to be called Getting to the Ideal Behavioral Health Crisis System: Essential Elements, Measurable Standards, and Best Practices. And we've been busy at this for about 4 years. Last June, we came out with what we called a pre-release draft of this document, and we sent it to a number of people around the country who we knew were interested in crisis services, including other ISMIC members and NASHBID and people, in the managed care world and people developing crisis services. And I know some of the people who registered for this webinar were part of our reviewer group, and we got a wonderful set of responses, which we've been working since then to incorporate into the next draft, which we intend to be releasing a bit later this year. And we're actually meeting later this week virtually to synthesize all of the work into the next response and to the next version of this material. And we already have a publisher interested, and we're thinking of a variety of different ways of putting this out there so that communities and policymakers and so forth could begin to use this material to advance their own crisis systems in the direction of the idea. In the way that this is put together, one of the things that's really important is for folks to begin to think, just like with other services, just essential community services. As I said earlier, a behavioral health crisis system is a lot more than just a crisis program. And it's important to realize that, you're looking at a population health response for people in the community who have a tremendous variety of presentations and complexities. And the system needs to be an interlinked set of services that is organized and held accountable to meet the needs of the community as a whole. So when we put together the framework for a behavioral health crisis system, we began to realize that there needed to be 3 different levels that all intersected in order to create a system that could provide the right service for every person in the right place every time. The first level are a set of structures and processes at the community level for accountability, for holding accountability, quality, and financing for the behavioral health crisis system. And I'll be talking more about that in a minute. And then the second level is the actual continuum of crisis services and capacities within that system. And then third, there are an array of clinical best practices that need to be operationalized throughout the crisis system. And those best practices are well known, but they're not consistently applied. And just like everything else, those best practices need to be operationalized within an accountable structure, as well as throughout all elements of the continuum. And these are fundamental features of designing any kind of system of services within behavioral health and elsewhere. And we often take them for granted when they actually are in place, but we have not been thinking that this is something critical for us to be doing. And now, as many of you may be familiar, part of recent federal legislation and recommendations are that we move to implement a national behavioral health crisis number, which is 988 is the proposed number. And SAMHSA is actively working on trying to figure out what needs to be put in place to do that implementation. Creating that kind of number starts to stimulate the need for local communities to develop all of these elements. And historically, when 911 was first put into place, it took about a decade for communities to get their local 911 systems up and running. But now it's something that we've learned to count on. And hopefully over time, we'll have the same level of development for behavioral health crisis services as a way of, having a proper, a clinically driven response with minimal, involvement of law enforcement, not with law enforcement being the first people to respond to all behavioral health crises, and helping people get the best service that they need to, through the continuum. So this is a visual of all of this fitting together. At the center, in our report, we have a person named Mr. Y, who becomes kind of a model for how the current behavioral health crisis system doesn't work, and emphasizes that the whole point of all these interlinking dimensions are that the person in need is at the center. And then right around that person in need are the secondary customers, which are that person's support system, family members, and so forth, as well as police and other first responders that may get involved in certain crisis situations. And then those people, have clinical best practices response within an array or a continuum of services and capacities that are held in place by a system of accountability and finance that has all of those elements involved. Now, one of the, and let me go back for a second. One of the things that we've done in our report is that each and every element that's part of the essential elements, and is structured, and I'll be showing you this at the end, into a set of measurable criteria that can be operationalized in any system. So this report goes into a lot of detail, not just about, these are good things and you should do them, but if you're intentional about developing this in your own community, here are the standards that you should pay attention to figure out where your system currently is, and then how to make progress in the direction of implementing things according to a specific set of standards and criteria. This is very similar to what's already in place for emergency medical services, but to date, until very recently, there has been no such guidelines for behavioral health crisis. So the first thing that we did is to emphasize that everything has to be informed by a set of principles and values. Ideal behavioral health crisis system are based on a shared set of values that across the community, that they're welcoming and engaging, customer-centered, hopeful, safe, compassionate, empowering, recovery-oriented, trauma-informed, and culturally appropriate. The system is accountable for all people and populations, not just for a subset of the community. It's designed with the expectation that people who have behavioral health crises have complexities and comorbidities, mental health and substance together, cognitive impairment as well, medical impairments, and challenges with housing, criminal justice, child protective service involvement, adult protective service involvement, and so on. They are designed to be both clinically effective and cost effective. It's understanding that a crisis system has to use available resources smartly, but to do it in such a way as to produce the best result for the community as a whole. The system is designed to be welcoming and engaging, and within that, there are times when involuntary intervention needs to be applied to help people be safe, that the system is designed to constantly improve through sharing and using data across all of the services, which is also something that emergency medical services do routinely. Now, here are the elements of an ideal crisis system. I'm going to go further into detail. So first of all, thinking about your own community, who's accountable for the behavioral health crisis services within your community? And many communities do not have any clear accountability for the provision of those services At the systems level, there may be individual programs that have responsibility for what they do, but most communities don't have an accountable entity for behavioral health crisis system for the whole community. And if that seems like a weird concept, most communities have an accountable entity for their emergency medical services system. An ideal behavioral health crisis system must have both a mechanism to finance and to implement a comprehensive continuum of crisis services that matches the population, and a mechanism to ensure oversight, accountability, and quality of the performance of that community. And in many communities, this begins with people coming together and saying, we're not sure we want this, we're not sure how to get there, but we're going to build a collaborative of key stakeholders that's going to be moving in that direction. So within this section, some of the key takeaways to think about in your community are, how do we make progress toward having an accountable entity? Is there someone who is responsible for the performance of the system as a whole, crisis system coordinator, rather than just for one particular service within the continuum? And do we have a collaborative that works across all the different boundaries and stakeholders to be, to monitor and continuously improve our delivery so that people get the desirable result? Secondly, all payers contribute, all community members are eligible. And I'm going to talk a little bit about financing later on. But the essence is that we should have one behavioral health crisis system, and it shouldn't depend on what your insurance status is or isn't. And that should not be the first question that you're asked when you call for help. Just like for other types of community essential safety services. The capacity should be commensurate with population need. And so that saying, oh, we have a crisis unit, let's say we have 16 beds that serves a population of 1 million people, is not commensurate with population need. It's not enough to just say, yes, we have one. We need to think about how that what we have is matched to the level of need within our community. And that by the same token, geographic access is commensurate with what we have come to expect for medical, urgent, and emergent care. We hold on formally to a high quality goal that every customer gets the right response every time, with continuous monitoring of individual results and collective performance. And there's a defined set of quality standards with continuing data shared for continuous improvement. The second section looks at a comprehensive array of capacities and services within the system. It says an ideal behavioral health crisis system has a comprehensive array of service capacities, a continuum of service components, and adequate multidisciplinary staffing to meet the needs of all segments of the population. So this, the components of this have several different slides. So here are some ideas, some parts of the standards for capacities. Welcoming and safe access for all populations, for all levels of acuity, and for people who are both voluntary and involuntary. First responders are priority customers and partners, but very importantly, the crisis response begins early, well before 911 or 988, and continues until stability is regained. That is, people do not have to be in the worst possible crisis before the crisis system responds. Just as if you smell smoke in your home and you call the fire department, they don't tell you to wait until you see flames. They respond quickly. And the idea of a crisis system is we should make it easy for everyone involved to get help as soon as possible and respond as quickly and effectively as possible, rather than having our systems built around people decompensating to the greatest point before they leverage response. Within this, there is an organized central element of capacity for sharing information, managing flow, and keeping track of people so that people don't get lost as they're moving through the continuum. The continuum responds to people of all ages and people of all cultural backgrounds. The services are designed with capacity to respond with the expectation that people will have both mental health and substance needs, often with cognitive impairment, often with health issues. People with active substance use are welcomed in all settings so that people are not screened out based on the presence of substance use issues. And medical screening capacity is designed into the continuum so that people are not sent unnecessarily to emergency rooms simply to get simple lab results or because of high levels of medical screen out that create burden in excess of what the standards for medical screening actually are. For the elements of the continuum, here are the common elements. These are replicated in the SAMHSA standards as well. Some sort of crisis call center that responds to both 911 calls and non-911 calls, that has the capacity to dispatch mobile crisis, both with and without co-response with law enforcement for safety issues. Some sort of crisis hub, which involves a combination of a walk-in urgent care with a secure crisis access center, often combined, although urgent care capacity can be disseminated more widely in the community, walk-in behavioral health crisis centers or capacities. And then there's a continuum of components, the capacity for 23-hour observation, often in the secure access center, residential crisis services, and we go into some great detail describing the different types and elements of residential crisis services, which unfortunately don't have common language from state to state, so different states have different names. But there has been a recent publication about national standards for crisis residential services, which has been very helpful in advancing this discussion. Peer respite programs, sobering centers, and the like. The capacity to provide for people who need medical emergency rooms, the routine expectation that there's psychiatric capacity in emergency rooms for those people who need the medical support of an emergency room. An array of psychiatric inpatient care for all ages and including specialized services for people with particular kinds of needs. And very importantly, continuity of crisis intervention capacity, both office-based and home-based, that allows people, so the crisis isn't one and done. It routinely leverages the capacity for transition planning in the community, moving the person from the crisis episode into routine care, noting that there's a big gap between, let's just say, having an inpatient or brief crisis bed admission and then having to go into routine outpatient services, that people need more intensity and wraparound to help them make those transitions. And finally, a transportation system. EMS, meaning ambulance-based transport, including the emergent capacity of ambulances transporting to other than emergencies through the recent ET3 waiver implementation that allows ambulances to transport to crisis centers on a pilot basis in communities. And then non-EMS transportation, where communities have transportation systems to get people to the place they need to be if they don't have their own transportation without having to invoke the cost of an ambulance or a similar kind of service. In addition, we need to design the crisis system to have capacity for the full age range, complexity, people with all different kinds of cultural and linguistic backgrounds, with plans for people who are immigrants, including people who are undocumented, people who are homeless, people involved with the criminal justice system who may be have already been arrested or booked, people who are veterans, and so on. And that we need to plan for the staffing capacities of the service so that just like in medical emergency rooms, we have multidisciplinary teams for behavioral health crisis, including peer support in all components is very important. And we assume that crisis services are a high need area for clinical excellence. So we need clinical and medical leadership, whether on site or remote, consultation, and leadership available commensurate with that for emergency medical services. The third layer of designing an ideal crisis system is the implementation of clinical best practices. And it says an ideal behavioral health crisis system has guidelines for utilization of the best clinical practice for crisis intervention with associated processes for practice improvement and workforce competency development, which is not just training, but a whole structure to ensure that people actually have the practice supports in the workplace to do the right things by policy, procedure, practice, paperwork, supervision, et cetera. Because this is a high risk, high need endeavor, and we want to pay the same level of attention to it that we do for other, as I said, other essential community services. So here are the examples of the kind of core competencies and practice guidelines within an ideal crisis system. None of these things is rocket science, but it's important from our perspective to articulate that we have an expectation of knowing to do the things that we know are the best practices. Welcoming, hope, safety first. Clear instructions for providing engagement with all collaterals, sharing, information sharing with collaterals, and by collaterals we mean family members, loved ones, other service providers, and understanding the ability of and the necessity of information sharing when someone is in a life-threatening crisis in order to determine the best result, and to make sure that HIPAA and other confidentiality restrictions are not unnecessarily standing in the way of appropriate information sharing. Staff must know how to develop and utilize advanced directives and crisis plans, formal suicide and violence risk screening and intervention. No force first is a required standard of practice, which is a technology related to, as it says, responding to people with welcoming and safety first and holding on to any kind of restraint or physical intervention only if absolutely necessary. Facilitative risk screening guidelines for medical and substance-related issues. There are standards for medical screening that are starting to be operationalized that minimize the degree to which medical screening creates unnecessary barriers. I'll be talking a little bit later about, how to respond to people who may show up with substances on board and how to do that in such a way that it facilitates access to care. Peer support in all settings. Behavioral health crisis settings, not only having access to using medication for mental health issues, but also increasingly being places where people who may present with serious risk, substance use disorders, can have initiation of medication-assisted treatment, whether for use disorders or opioid use disorders. Having a set of practice guidelines for crisis response to all different kinds of ages and populations and complexities, and the implementation of known best practices for crisis intervention, like critical time intervention, to promote successful continuity and transition. So now I'm going to give you some examples of the way this particular report is structured. And I'm going to do one example for each section just so you can see the level of detail that we've been working on in this report. And hopefully you'll all be eager to read it when it comes out and find that it will be useful for making progress in your own system. So this is one of the many sections, many specific elements of the first section, accountability and financing. The full list is in the big circle that I showed you earlier. So financing. So for each element, essential element, there's a rationale. A comprehensive behavioral health crisis system with a complete continuum is essential element of safety net service, etc. For this reason, that continuum of service must be adequately financed to achieve appropriate community's response, just as is the case for other safety net services. I want to emphasize that because you never hear a community saying, I wish we had a fire department. I guess we'll wait until we get a grant. Otherwise, we'll just rely on volunteers with buckets. I mean, maybe there are small communities that do it that way, but everybody is organized to do these things. Further, alignment of multiple funding streams to support a single crisis system rather than each funder developing its own system is likely to be more efficient, effective, and accessible for customers. And then we have section measurable criteria. The accountable entity is responsible, and there's an accountable provider providing coordination that has the following approach. There's a global budget. The financing is designed to support capacity, not just utilization. There's an effort to design that capacity at or near the peak need, okay? So that there's only rare times when the utilization outstrips the full capacity of the system. All or most potential beneficiaries of the continuum are accountable to contribute resources. This includes state resources like Medicaid, direct state funding, local funding, all types of insurers and managed care organizations, as well as health systems who are responsible for what happens in their emergency services. The system should be designed so that there are incentive payments for the quality. There are adequate reimbursement rates. There's payment for all of the elements of the continuum, which does not currently happen routinely. Payment for all populations, including those with comorbidities, and there has to be instructions about how to access payment when people present in crisis with different types of complicated comorbidities. And financing mechanisms are designed so that the system operates as a safety net for the entire delivery system comfortably, if you will. So that's one example of one of the elements of section 1. Here's section 2. This is a piece of capacity. I chose to show you this because it's something very often that folks don't think about. When I operated a crisis system in Massachusetts years ago, this was part of what we designed our crisis system to do. And that is that, you want your system to be proactive in providing support to community providers so that they have a sense that the system is holding their back when they're working with folks who are at risk. And those could be outpatient providers or residential providers and so on. And this is a core capacity of the continuum. A comprehensive behavioral health crisis system with a complete continuum is an essential element. As such, an essential component is for the crisis system to not only react, but to engage in outreach and consultation with all elements of the routine community service system to address risky situations early and to prevent crises or escalation of crises through outreach and contact. And here are some examples of measurable criteria. There are formal mechanisms for routine and as-needed outreach and consultation, training on access to crisis services, de-escalation, routine consultation to high-risk settings, such as residential programs, schools, assertive community treatment teams, emergency rooms, proactive consultation and case review for high-risk cases, quality indicators that include these elements are built into the standards for the continuum as a whole. Okay, and here's an example of a set of practice guidelines. Okay, and this is one particular one that, as you could tell maybe from the introduction, is very important to me, is that people with active substance use are regarded as a priority for crisis response because these are folks who are higher risk. And there's a lot of practice currently where people who may show up intoxicated are regarded as people who need to somehow be turned away or not responded to until they're sober. And that needs to be flipped around. So in this example, individuals with and families with active substance use of any kind are welcomed for crisis and viewed as a priority population for engagement and care. In programs responding to mental health crisis at any level, people with co-occurring substance are similarly welcomed and prioritized. No provider of crisis services shall have a formal or informal policy that creates barriers to access based on requiring that the person must demonstrate that their alcohol level is below a certain number, or that their urine screen must be completed and cleared prior to initiation of crisis services. If person is too intoxicated to communicate coherently, the assessment begins with welcoming engagement, contact of collaterals, history, with a plan to initiate conversation as soon as the person can begin to communicate clearly. This position is made as soon as possible. All crisis providers shall have policies and protocols to manage individuals who may be intoxicated in a welcoming and safe manner, and to provide support for withdrawal management commensurate with the level of medical care they do or do not offer. This, this is the last slide with content. And what I'm illustrating here is the ability to conceptualize all of these things. What I'm going to do is go back to the diagram just so you can envision the whole thing together. Here it is. Accountability and finance, an array of services and capacities, clinical best practices, okay, all wrapped around the right service in the right place for every person every time. And I wanted to open it up for discussions and questions. Here's some things to think about. What can you do to begin to articulate this vision for your community and start to make slow steps of progress in this direction? Are there other standards you guys would think about and want to include? Other ideas about how to make this work? And thank you very much for listening.
Thank you so much, Dr. Minkoff. I think I can speak for everyone in saying that this was an exceptionally comprehensive webinar detailing your work that you've been engaged in over the last 4 years or so to develop the ideal behavioral health system. We did have, a question come in about how to account for overworked social workers from Gianna. And I'm not actually sure, it looks like it was embedded in another question, but I think the question might be pertaining to burnout.
So I'm reading the question. It says, how does this work in a system that is already overrun? So, I think that's a very important question. So let's take a breath. I don't think there's the behavioral health crisis systems in the United States that do not already experience themselves as overrun are probably countable on no more than 2 hands, maybe even 1. And part of the point of doing this is to illustrate that that the reason that our systems are overrun is because they're under-designed and resourced, because they're an afterthought. And so the fact is that almost every behavioral health crisis system is designed so that it has less capacity than people need, than the population needs. It's less accessible. There isn't a full array of services. And it's commonly designed so that the system has no ability to respond effectively until the people are as sick as possible. And, so we say, well, what can we do? We need more money. We need more resource. And part of the message here is to shift the conversation. And if you guys get nothing out of this other than what I'm about to say, then that will be valuable. Let me go back to the beginning, okay? Every community has fire response, police response, emergency medical system response. There's not a single source of, there's not some state grant that provides all that for you. The community creates it out of existing resources because it's essential. The message here is that every community needs to be thinking that its behavioral health crisis response should not be overrun and stop waiting for someone else to fix it. Every community can come together and think, okay, we're not going to get there overnight, but let's articulate what our community needs and start thinking about the resources that are already available and potentially being misused in order to get a more desirable response. I'm going to go to the next question on my question and answer list. How do you get buy-in from the different partners and governmental agencies? And then you mentioned community task force. How do you initiate those? One of the things is, I'll just use an illustration. Currently, Zia Partners is part of a consulting team that's working with a community in Michigan, in Kent County. And, that's a community like many communities that recognized that the way that their behavioral health crisis system was designed wasn't working. And people were, stuck in ERs, and there's, there was a concern about inappropriate law enforcement involvement and people being arrested who didn't need to be arrested, and all kinds of gaps. So, the community came together and said, we need help. So the starting place for the help is, when you say, how do you get buy-in? You don't need to start with everybody agreeing that they're somehow going to fund something when they don't know what the something is. It starts by acknowledging that this is our community, and let's look around and see who are the concerned partners in the community that are interested in trying to figure out how to make it better. So in this particular county, there's the county. There's a county executive who's taking on a leadership role, and up until the COVID response, of this in the health department as something to try to figure out. They brought together hospital systems, both psychiatric hospital systems and the big hospital system serving the community, because everybody was concerned about what was happening in the ER, and law enforcement and providers and the local public behavioral health entity that manages Medicaid for the community. Okay. And there's all kinds of other stakeholders that relate to children and relate to homelessness. And all of those are present in most communities. And you invite people to get together and say, let's try to figure out what's going on and how can we improve. And at some point they asked for help. And, we came in to use this framework as a way of identifying where they might want to head, which they got excited about, because they want something not just adequate, they want something excellent for the community. And, so we looked at all the things they had in place and say, so how do you build on what you have to advance this in the direction of what you're going? And that's kind of where we are with them appropriately, but, at the current moment. So the issue is there's no one entity that can be solely responsible for the whole thing. We talk to every insurer in this process, and they all have some ability to invest in contributing to this, for their populations. If everybody comes together and everybody contributes funding, it becomes something that has more ability to advance than if you're expecting one piece of the delivery system to fund this alone. And if you understand how your current EMS functions in your community, then you'll understand that that's exactly what happens in EMS.
I want to thank content expert Dr. Ken Minkoff. Thank you to everyone for viewing this webinar and for taking the time to learn about this important topic in the midst of so much that's going on related to our COVID-19 response.